Welcome to another Health Quest Live. I'm Heather Asti, and it's my pleasure today to introduce Dr. Nicholas Moore from Motor City Orthopedics. Dr. Moore has been taking excellent care of Health Quest patients for many years now, and he has extensive experience treating athletes of all levels, from weekend warrior all the way to Olympic and professional levels. He is the expert at diagnosing and treating chronic tendinopathies, as well as known for his use of ultrasound, diagnostic ultrasound, and dynamic ultrasound, to name just a few things that he does. He is joining us today to talk about carpal tunnel, something that's extremely common. We've all heard of it. We know people who suffer from it. A lot of people have Googled it and are self-treating on their own, but Dr. Moore is here today to tell us a little bit more about what carpal tunnel is and what the innovative treatment technique that he is using to correct that for people. So thanks for being here today, Dr. Moore.
Thanks so much, Heather. Appreciate you having me. Yeah, so I'm a primary care sports doctor. And so a lot of, I kind of treat the gamut of acute and chronic non-surgical stuff alongside my orthopedic partners, but a lot of stuff I do is with the ultrasound. So like Heather said, diagnostic ultrasound and various ultrasound guided procedures. And this new device allows for doing a carpal tunnel release under ultrasound. So we're going to kind of go through that. So we're going to go through carpal tunnel, and again, I'll probably skim through some of that stuff just for time's sake, but I want to touch on specifically the role of ultrasound in evaluating carpal tunnel, and then talk about this unmet need with how many people have carpal tunnel and are self-treating and doing all these things, but again are reluctant to undergo surgery because of the downtime and all that. So this is, and then we'll talk about this new device and way to do carpal tunnel release. So carpal tunnel is obviously compression of the transverse carpal ligament on the median nerve. It's very, very common, 12 million Americans. There's a couple risk factors there that are sometimes hereditary and some combination of manual laborers. Obviously, me doing ultrasound and you guys doing physical therapy are both relatively high risk factor for developing some of these symptoms. Pain and paresthesia across the median nerve distribution. Predominantly sensory, and as it progresses, you can get some motor symptoms and some weakness associated with it. That flick sign where the people feel that kind of numbness that wakes them up at night or first thing in the morning is relatively high sensitivity and specificity. Your differential is going to include arthritis of the thumb, some kind of radiculopathy, maybe peripheral neuropathy, other musculoskeletal things in the wrist, whether it be, some kind of flexor tendonitis or arthritis in the wrist. So you just kind of want to make sure you go through, ruling out, evaluating the neck and everything on down the line. The exam can be a little bit of a mixed bag, right? Like unless they have crazy severe symptoms, they might not always have tons of reproducible exam findings. We found that this square-shaped wrist, which is kind of deeper and wider, has increased odds ratio for developing carpal tunnel. But otherwise, you can get people that don't always have significant reproducible symptoms. Obviously, as it progresses, they can get lack of 2-point discrimination and weakness and atrophy and some of those things. So just to give you an example of, these various exam maneuvers, we think of the Tinel and the Phalens and all these things. They have relatively low sensitivity and specificity, just like anything, examining a shoulder or anything else. Once you start combining these things, it improves, but it just gives you an idea of how relatively poor some of those things are. So, what other additional testing is there, to try to confirm the diagnosis or determine the severity? So obviously you can do a nerve study where you're looking at how the median nerve is conducting, or an EMG where you're looking at how those muscles are innervating. And so that's going to give you the diagnosis. It can also obviously rule out involvement from some kind of radiculopathy or polyneuropathy. But again, it's not always 100% accurate. So ultrasound, you can actually diagnose carpal tunnel by measuring the cross-sectional area of the median nerve at the distal wrist crease. And so that's a relatively nice alternative in that it's low cost, it's a lot less painful and invasive than an EMG. And it's something we can do on the spot in the office. Obviously with ultrasound, we can evaluate other mass lesion, tendinopathy, other fluid like that, but it's not going to give you a gauge of the severity necessarily or tell you about polyneuropathy. here was the first study where they just started looking at measuring peripheral nerve cross-sectional areas kind of across the way. And so you can just see as a reference for the median nerve at the carpal tunnel, you're looking at about 8 millimeters in cross-sectional area. So in this study, they came up with a reference value of less than 9 being normal, borderline being 9 to 12, and over 12 being positive, with pretty good sensitivity and specificity. So again, you're putting the probe in, cross section to the median nerve at the distal wrist crease, and then measuring from the epineurium, which is that white hyperechoic around the nerve fascicle there from the inside of the epineurium, and getting this number of 0.12 centimeters there. When you turn the probe from short axis to long axis with the structure in the plane with the median nerve, here you can see the transverse carpal ligament is this bright white, and then the median nerve is the black, and you can see where it's getting narrowed or compressed there. We call that the notch sign. So you imagine if you squeeze a hose, you're getting enlargement of the nerve proximal to that area, and you're getting that notch sign or pinch in that long axis view. They went a step further, and if they had borderline measurements of the cross-sectional area, if you move proximally back to the level of the pronator and then measured the cross-sectional area of the nerve, if you get a delta of over 2 millimeters, that's 99% sensitive, 100% specific for carpal tunnel. So, relatively accurate. There was another study looking at hypervascularity of the nerve and associating it with those measurements of the size. There's another study looking at people that have a bifid median nerve, which is a risk factor for carpal tunnel, and again, getting a delta of over 4 millimeters correlated with those carpal tunnel symptoms. So what's the treatment? The conservative stuff is splinting, anti-inflammatories, physical therapy, and I don't know if Heather, you want to go into it, but the common stuff that you guys will do, nerve glides and mobilizing the carpal bones and doing some stuff with the flexor tendon, and then other ultrasound or other modalities. Obviously, people will do cortisone injections, which can have relief, but they're relatively, short-lived. So people can get, months of relief from that, or even up to a year. But again, they're still at over a year, still more likely to have to undergo surgery at some point. So the treatment for severe is obviously doing a carpal tunnel release, right? You're cutting and releasing the transverse carpal ligament and taking off the compression of the nerve. And whether that's done, through an open procedure or an endoscopic procedure, or what I'm going to talk about, it's all the same. It's all the same end game, right? So everyone's going to have the same result long term. It's just mitigating some of the short-term consequence. So again, at 1 year, everyone ends up being the same, but people that get in open or sometimes even endoscopic have, scars and pillar pain and some, prolonged recovery. So this was just looking at open versus endoscopic. And again, at 6 months out, it's the same, but people that had an endoscopic procedure are lower risk of scar tenderness, better return of grip strength, earlier return to work. And so here's the need. You have 12 million people with carpal tunnel and 600,000 procedures happening annually. So you have this huge gap of people getting treatment. And it's because, they don't want to get surgery or they don't have, can't afford the cost of the procedure, but, there's big recovery time involved and associated pain with it. So, there's kind of this big gap in what's being done. And so herein lies a good opportunity to help mitigate some of those factors. So using an ultrasound to guide carpal tunnel release is not necessarily a new phenomena. It's been documented out as far back as 1997. And there's been a good number of them done, and they've been done safely and effectively. But again, there's never been a specific tool to do that. So here's the idea, is that when you look at the transverse carpal ligament on the ultrasound, you're going to measure sort of the proximal row between the scaphoid and the pisiform, and the distal row between the trapezium and the hook of the hamate there. And then you're going to try to pass a device down through that quote unquote safe zone and release the ligament from there. So again, using various numbers of devices, it's been done on cadavers and clinically, and the first thing is just proving that it's safe and effective. And so that's been done a number of times. Here's another study with 550 no neurovascular complications, no incomplete release, no one having to go and do an open. So it's safe doing it this way. So here was looking at doing it with ultrasound guidance versus doing a mini open. And basically the results are that, again, same end game, but they're 5 times faster return to activity. So again, first step in anything is proving that it's safe and proving that it's effective. And so that's been done relatively well. But here's what they were using, right? Tools that they would do an endoscopic with, or different kinds of blades and resectors. So here's this device that was designed specifically for doing a carpal tunnel release. It's called the Sonex microknife. And so it is basically a handheld device that you can use in your one hand while holding the probe with your other hand. And then it has a balloon that inflates around the tip of the blade. And then that's done when you compress the top handle. And then when you press this little button underneath it, it brings back this little blade that comes back in a retrograde fashion and resects the transverse carpal ligament. And then it recesses at the proximal end there. So it's blunted on the front side so that it's not going to cut anything, and it's recessing so that it's not going to cut anything. And you can't engage the blade without the balloon being activated. So it's got some fail safes. So looking with the ultrasound, we're measuring the median nerve at the distal wrist crease. We're getting, enlarged cross-sectional area. We're getting that notch sign when we look on the long axis view. And then we want to measure, how much room do we have? So here we're looking again proximally between the scaphoid and the pisiform. And so this is our proximal safe zone, right? Between the median nerve, and then here's the transverse carpal ligament, and then there's the ulnar artery that's actually radial to the pisiform. So you have, somewhere in the realm of a 0.5 centimeter to 1 centimeter of space. And then you slide your probe distally till you're at that kind of distal taper of the transverse carpal ligament, which you can see here coming in and attaching on the hook of the hamate. So I'm measuring my distance from the hook of the hamate to the ulnar edge of the median nerve there. So that's distally. And then when I turn my probe in this back long axis in line with the nerve, you're following it out till you see the superficial palmar arch, right? So the ulnar artery comes up and branches across. And so I've got 0.85 centimeters from, again, here's the TCL, here's the taper of the TCL. So I need to cut from there back, and I need to make sure that I'm not advancing to the level of the superficial palmar arch. So I have measurements of how far I have side to side and how much room I have distally. And then obviously when you're scanning them, just like you're going to rule out other pathologies, you also want to see, here I'm looking at the palmar cutaneous branch to make sure that it's going radially and not going ulnarly across where we would be resecting. And here's the recurrent motor branch going through the thumb musculature there, again, radially, to make sure it's not going ulnarly. I mean, I guess if you saw that and it was going right across where you'd be doing the release, then maybe that is someone that you would say, you probably need to do an open release or something, so that they can very closely dissect around that little area.
How long have you been using this specific technique?
So this device came out in 2019, and it took me almost a year to get it approved. So we got it approved to do this at the hospital starting in December. And so since then I've done about 40 or 50 of them. So, and they've gone well. So this is a video animation of the procedure. So you are using local anesthesia to make a block under the skin, and then hydrodissect under the transverse carpal ligament so that you can then make a little incision, slide this device down to the taper of the transverse carpal ligament, press the thumb button down to deploy the balloon so you have safe zone side to side, such that when you start to bring the blade back, obviously you're protected from the median nerve and the ulnar artery, and then the blade recesses back through the device. So once you do that, you can either make a second pass if you need to with the device, or just be done. So here's just kind of going through the steps. So here, we have the ultrasound in a transverse plane to the distal wrist crease at the level of the lunate, and you're making a wheel under the skin, and then you can kind of just pass your needle down so that you can see that you're under the transverse carpal ligament over those flexor tendons, and then watch your needle hydrodissect, right? So we're not, poking our needle down there, we're injecting fluid volume and then following with the needle until we get this fluid tracking all the way down to the distal taper of the transverse carpal ligament. Then once we've done that, we can, again, make a little incision such that we can, usually there's a little like blunt dissector that you can make sure you can pass all the way through. And then you're going to take the device and slide it down underneath the transverse carpal ligament in that short axis where the device is out of plane with the probe, and then turn the device long axis and see that it's making it all the way down to the distal transverse carpal ligament. And you're staying shy of the superficial palmar arch. And then once you're there, you press down on the top lever that activates the balloon around the device, right? So you can, sometimes the anatomy gets real tight, but once you've activated that balloon, it kind of pushes it off to the side so that you have a clear area to start to engage your blade. So usually you'll start in that long axis view so that you're clear of the superficial palmar arch. So you can watch and see, here's the blade activating, okay, at the distal taper. And then you turn the probe so that you're short axis to the structure again, and there's the blade tip. And then you're gonna slide the probe slightly proximal, engage the blade into the plane of the probe, slide the probe slightly proximal, engage the blade into the plane of the probe, so that now you're seeing all the way along the way that you're not affecting either of the neurovascular structures ulnarly or radially. So, I mean, you can see that why this is safe, right? And it makes, again, it's been a little bit of a political thing in that not a lot of hand surgeons do ultrasound, and not a lot of hand surgeons want people like me doing carpal tunnel release. And so, they're going to say that, oh, you're going to get a neurovascular injury, but really you're not going to engage a blade anywhere where you can't see what you're looking at, And so you have these safe zones that you've marked. You're watching that your blade is proximal to the SPA, and then you're turning short axis and watching that your blade is in between the artery and the nerve all the way until you've released through the transverse carpal ligament, and then your blade is resected and clear. And so, I mean, as long as you know what you're looking at, which can be a little bit tricky, it's relatively foolproof. And then afterwards, you can take your little blunt dissector and pass it through. And so the left shows you beforehand, where you can't bump through the TCL. And now you can kind of watch your probe pass up and through the transverse carpal ligament. And you can do that again at the level of the hook of the hamate, which is distally. And then you could slide it to the proximal transverse carpal ligament and see that your probe is passing through it as well. So it's relatively definitive, right? And you can confirm it. So again, here's just another examples, hydrodissecting, bringing your blade to the taper, activating your blade in the long axis view, turning to the short axis view so that you can see that you're clear side to side, activating your blade, moving your probe proximally and bringing your blade into the plane of the probe until you're all the way through. And then afterwards, again, you can take your probe and see that it can go all the way, probing all the way through volarly to the transverse carpal ligament. So that's it. It takes about 10 minutes or so. Again, everyone's anatomy is different, and some are easier and some are harder. You might have to, play with the extension in the wrist, or, if the anatomy is real tight, you might have to kind of lean the device toward the ulnar wrist so that you're, out of the direction of the median nerve. And there's little tricks of the trade that I'm picking up the more and more you do it, but it's the same end game as releasing the ligament. So afterwards, we put little steri-strips on this incision that's a few millimeters. It doesn't need stitches. And then we put a little tegaderm over that so they can, shower with it for the first couple of days and let the steri-strips fall off on their own. And, they can ice it on and off. We put a little ACE wrap over it. And then, relatively common post-procedure instructions. Again, I mean, they don't need to be immobilized. They're in a big wrist brace for forever, because for the most part, my understanding is that's protecting the the incision. And so since the incision's so small that you don't have to really worry about that, and again, we're not going down through all these layers of soft tissue. So we're not cutting through the palmar aponeurosis and the palmar fat. And so there shouldn't be as much associated soft tissue injury. And I think that's what allows them to recover so fast. And then I usually see them back in the office a week later and see how they're doing, and then kind of go from there. I mean, there's really no, post-procedure PT protocol or OT protocol. I mean, and that's the part that is, maybe Heather, if you want to chime in, just, kind of is trying to figure out with who probably needs therapy afterwards and who doesn't. I mean, people that, so far my experience is that people that maybe went into it having some weakness are probably going to benefit from doing therapy right away. People that have to progress to a little more manual lifting and loading, might need it right away. But it's a little bit of moving target. I mean, I kind of see where they're at a week out, and if they're doing, I mean, some people are just like, the numbness should go away like in a day. They might have some residual pain, but again, a good number of these people are doing great a week out. Some people still have some soreness, but the numbness is gone. And so, it's relatively uncomplicated beyond that. So, yeah, I mean, maybe Heather can pass along my info to everyone. I mean, I think I have, I probably have a lot of your numbers and stuff, but I'd love to hear from people on what they think about, the rehab side of it, and who maybe would be, a good candidate for doing some PTOT. Yeah. So there's almost been 7,000 of these done now since this device came out, and it's probably closer to 50 physicians. Again, there's me and one other guy in Michigan doing this over in the Muskegon area. And it's the same CPT code. It's a carpal tunnel release. It's no different. But again, hopefully these people are getting, relatively quick relief of their symptoms without big adverse reactions and maybe less adverse reactions. So I don't want to spend too much time going through all this, but here's the literature on the first few ultrasound guided carpal tunnel releases. And again, just proving that they're safe and they're effective. And again, you can see that was kind of the end result of that first study. This study was comparing them to mini open. And then again, you can see the return to normal activity was 4.9 days compared to about 25 days. So here was one that was looking at these performed by someone like myself, a primary care sports doctor, not specifically a hand surgeon. And again, just seeing that he did 22 cases and they were, relatively safe and effective. So again, when you get to 6 months, it's all unchanged, right? But what we're talking about is A, they don't need surgery, so they don't need the risks of anesthesia and that kind of stuff. But B, they might have a little quicker resolution of things. So you might be able to do this on people that otherwise couldn't tolerate surgery, or you might be able to do this on this big gap of people that have this, but don't want to go through the big prolonged recovery. So, just comparatively to even, looking at doing it endoscopically, at that 2 week, even 3 to 4 week mark, you have, much improved symptoms there.
Right.
And then we have them fill out, they go through kind of a survey score before they do this, and then sends them messages every day until their symptoms have resolved and they're back to all their normal activity. So this is something that we can track. Again, I mean, it's the same code as a carpal tunnel release, but the device itself has a cost. And when they do it in the hospital, so we do this in a little procedure room, ultrasound room, it's covered under their facility fees and all that kind of stuff. But once I get enough of these, I can take it to Blue Cross and say, hey, this is how much the hospital is charging for this to be done. And I could negotiate a rate for them to just do it in the office. There's no reason why they couldn't just do this in the office, and it would be even simpler. So that's maybe the long-term thing, but obviously we want to track this to see that people are doing well, which they've done a pretty good job of, but then, maybe you can cut out having to go to the hospital. But, where we do it is relatively easy. They check in the imaging area and they get brought back, that we have a nurse and an ultrasound tech, and we, monitoring their vitals and do it just under local. And so it's pretty quick in and out with them having to go like pre-op and all that kind of stuff. So again, you're looking at a really return to work in just a few days. And so that's it. That's the long and short of it.
Well, it sounds like a really great advancement, because what do most of our patients want? They want to get better faster. And it sounds like that's the end game here is they're going to get the same relief from carpal tunnel, but get a return to kind of their daily life faster. And, even better if they don't need PT in the end, because, in a lot of cases, we're seeing these people, at least from the physical therapist perspective, we're going to send people to you that have failed their PT measures, that aren't getting better fast enough. So just having an option for the public out there where they can get, quick results, return to function, is a huge improvement. Huge. So I appreciate it.
It's really cool technology. I'm excited about it. Again, we're a sports practice, so we're not necessarily busting at the seams with carpal tunnel patients. So I'm just, it is kind of a little treatment gap where, I think it's just going to take a little time to get the word out, but I think it's going to do great. And eventually more and more people will be doing it, I'm sure, for these reasons.
Right. So from your perspective, is there an ideal person for this procedure, either from, speaking to physical therapists or to the general public? Who is best for this procedure?
I think it's anyone that has carpal tunnel. Again, when we do the diagnostic scan, we're going to make sure they don't have some abnormal variant of, the recurrent motor branch or something like that would preclude them. But for the most part, there's more things that are going to preclude you from a medical standpoint from getting surgery than from doing a local only procedure. So it's not like anyone's really better or worse. I can tell you which ones are easier for me to do than are harder to do it. Again, when you talk about, how thick the palm is and those kind of things. But, I would say anyone that has carpal tunnel should come in and then again, we'll do the ultrasound diagnostically and measure you and go from there. If it's equivocal and we need to do nerve studies or more things, we can, or if it's not carpal tunnel, it's something else, we'll treat it that way. But that's how we'll start.
Excellent. Well, I so appreciate you sharing this with us today and all this good information, both with our therapists and with our general public and our clients. We'll appreciate this. To everyone watching, if you have found this information helpful, as always, you can like it and share it. Send it out there to people that might be suffering with carpal tunnel. And if you want more information on Dr. Moore and Motor City Orthopedics, you can check out their website at motorcityorthopedics.com. And you can also check out HealthQuest's website at www.hqpt.com. You can check out our locations and even schedule a consultation online with a therapist near you. So thanks again, Dr. Moore, for sharing everything with us that you did.
Thanks, Heather. I appreciate you.
Yeah, so take care, Dr. Moore, and hopefully some people will be seeing you soon that have some problems.
Sounds good.